Hi, good evening, everyone. Thank you for this opportunity, Nandana.
Thank you. Thank you for joining us and agreeing to join us. Thank you so much.
Thank you. It's an absolute pleasure.
Good evening, everyone, and a very warm welcome to all. On behalf of IAP Allergy and Applied Immunology chapter, it gives me immense pleasure to inaugurate today's webinar on allergy diet dilemma: what to eat, what not to eat. Dietary choices play a crucial role in allergy prevention and management, yet they often remain clouded by confusion, myths, and incomplete information. This webinar brings together distinguished experts who will help us to navigate the science, the challenges, and the practical aspects of diet in allergic diseases. I am confident that today's deliberations will not only enhance our knowledge but also empower us to guide our patients and families with clarity and confidence. Let us look forward to an engaging, insightful, and solution focused evening. So, with this, I would like to invite today's curator, I will say today's creator, today webinar creator, Dr. Nandana Bala. So she is senior pediatrician and allergy specialist. She is currently affiliated with Rainbow Children's Hospital and Prudent Health Specialty Clinic at Bangalore. So Dr. Bala ma'am, you are very much welcome, and thank you very much for curating all this webinar today evening. Thank you.
Thank you. Good evening, everybody, and thank you so much, Dr. Neeraj, for your kind introduction. I'm so grateful to you and as well as the IAP Allergy chapter for this opportunity to organize this webinar. And, I'm very thrilled and privileged to have with us tonight eminent multidisciplinary faculty for the discussion on the role of diet in allergy. So a very warm welcome to all of you once again. And we have Dr. P.A. Mahesh sir, Dr. Malti, Dr. Balchandra, Dr. Priyanka, Dr. Lavanya, all of you have joined us, and some other senior allergists are here with us too. We will be beginning tonight's session with an introductory talk by myself. I'm a pediatric allergy specialist practicing in Bangalore. And I will be giving some perspectives on the origins of allergy and the role of diet in this very complex process, some of which we understand and some of which we don't yet understand. And this will be followed by a session on the lessons from the Europrevall study by Professor P.A. Mahesh sir. And so following this, we will have a panel discussion moderated by Dr. Balchandra, who is again a very senior pediatric allergist based in Bangalore, with a panel of eminent allergists and gastroenterologists participating too. So I will start my session now. I will start screen share. Hope that's okay. I would request one of you to confirm that you can see my screen share, please.
Ma'am, so your screen is visible. Please go to the slideshow.
Yes. Yeah. Thank you so much.
Yes, ma'am, it is good. You can start.
Yeah. Thank you. Yeah. So I will kind of set a scene for today's session. And so the diet dilemma in allergy from preconception to adulthood is what I am trying to cover today. And I will start off and then my colleagues will take over from me. So I will go through some of the recent scientific evidence with regards to the prevention and treatment of allergic diseases, focusing on the diet. So what to eat, what not to eat, very frequent question that we are faced when we see our patients. And what are the foods to avoid? So, almost on a daily basis, we have to answer these questions. And what is the scientific basis to answer this? I will kind of try and go through. So the aims of this session, I would like to present to you with an evidence summary of what we advise and why we are doing that. So I will give a perspective of allergic diseases as a whole. How did it start? Where are we heading? And the role of diet, in particular, concentrating on prevention and treatment also. And my talk is kind of a wake-up call to the extent of the problem. And to be honest, as I was preparing for this, for this session, I was worried about the future of our children and of the population in general in terms of the allergy pandemic. I think we all really need a wake-up call. And so prevalence of allergies, including food allergies, have increased dramatically in the past few years. And in food allergies, as we all know, there has been a paradigm shift from an idea of avoidance of certain foods to early introduction. And I would like to take you through that that journey. And let's look at the evidence base for diet and allergy. So the key questions I will try to address, I may or may not have answers to all of them, but how does maternal diet influence allergy risk in their offspring? What role does diet play during pregnancy and lactation? How and when should allergenic foods be introduced in the child? And how do we manage dietary interventions in childhood and beyond? And as I said, I will start off with a general overview, and then we have a very detailed panel discussion regarding the specific issues by absolute experts and authority in the field. Okay, so the allergy epidemic. So in the kind of the late 19th century, the allergic disorders started off. So it's not that we did not have allergic disorders before that. It was certainly there, and there are a lot of instances in history where we find some examples of this. But certainly we started to see more and more cases towards the end of the 19th century, and then there was a quite a rapid increase in the 20th century, and we are now here in 2025. This is a beautiful paper in 2015 published in the JACI about the allergy epidemics. And what you will see here, if you look at the figure on the right side, I hope you can see my cursor, is that there was a sequential rise in 3 different types of allergic diseases. And very interestingly, we will find that in the late 19th century, you had the allergic rhinitis increasing quite a lot. And then there was a bit of a plateau. And then you have in kind of the mid 20th century, you have the asthma increasing, and then we reached a plateau. And then towards the late 20th century, you had a very dramatic rise in allergies that were seen. And particularly people started to see fatalities with food allergy. And that was, very alarming at the time. So the other thing to realize is that, there were key events that are associated with some of these rises. Like, for example, the post-industrial revolution, and then you had, the sanitation, which came in with the clean availability of clean drinking water. You had helminthic eradication, etc., that happened. And then after that, you had this rise that is seen. So people are trying to put together what exactly caused this allergy epidemic. Now, because we are talking mainly about the diet, the food allergy is called the second wave of the allergy epidemic. So you all saw that we had the respiratory allergies with the allergic rhinitis and the asthma, and then you had the food allergies rising quite dramatically. So that is referred to as the second wave of the allergy epidemic. Again, this I would like to refer to this very important, very nice publication by Dr. Susan Prescott and team in Australia. They have done a lot of work on this, and I would suggest that all of you go through this article. And essentially, there are some very worrying aspects that have come out. Okay. So in the first wave of the allergy epidemic, as I said, there was inhalant sensitizations with asthma and allergic rhinitis. And countries like Australia led this respiratory epidemic. Okay. And then once the second wave came, we had the food allergy epidemic. And again, Australia was one of the countries which saw a dramatic rise in allergies. And this lagged, the food allergy epidemic lagged behind the first wave by several decades. And it's as yet unclear as to why this happened. Challenge-proven IgE-mediated food allergy now affects 10% of infants. That is staggering. This is obviously Australian data, but they are leading and everybody else is following. So, this may be, a harbinger of things to come in the future. And the new generation is less likely to outgrow food allergy, is what they are finding. This again is very worrying. I'll show you some specific data later. Modern lifestyle, change in dietary patterns, change in our intestinal commensal bacteria, vehicular pollution, all of this are contributing. And new studies suggest environmental factors can produce epigenetic changes in gene expression, potentially causing heritability across generations. Now, this is something that we all have to be very, very worried about and really mindful of. And how can we prevent this is what we need to find out. Also, preliminary evidence suggests that non-Caucasian populations, which is us basically, may be even more susceptible to the adverse effects of westernization. And we do see this in patients of Asian heritage who are born abroad, where their incidence of allergies and even the severity is much higher than the local population. And again, this is very worrying statistics and substantial global implications with progressive urbanizations of the more populous regions in the developing world, which includes India, means that we will soon follow this kind of a staggering epidemic that is being seen in the West with regards to food allergy. Unraveling the environmental drivers is critical to curtail a potential tsunami of allergic diseases. Now, this is how Dr. Susan Prescott has referred to the, food allergy epidemic that we're going to see. She has referred to it as a tsunami. So I just thought, let's start at the very beginning, which is a good place to start. So our ancestors lived like this. And then, as civilization progressed, we kind of progressed like this. So our ancestors used to eat what they found in their environment, be it animals or, plants, etc. And then we kind of, we became agriculturists and we started growing our own food. But we held on to our traditional food habits, which were really quite healthy and protective. And then what happened is something like this. So we started eating very differently to our ancestors, and it happened quite rapidly instead of the gradual progression that happened in the early times. Okay, so we started eating in kind of nearly sterile environments and on very clean, sterile plates, and eating foods that were heavily processed, something like this now. And it's very worrying, the trend that we see in India. If you step out into a grocery shop, more people are buying packaged chips or biscuits rather than, fruits or vegetables. And that really worries me. And we even have baby foods. Even babies are being fed this processed food. And this change is now taken over quite a lot in urban India too. And this trend is something that we have to really work on. And as pediatricians, we have a responsibility to prevent this from happening. Certainly food for thought, isn't it? So also just wanted to highlight that in history, this is a paper in 1989 where Dr. David Strachan, the very kind of famous paper where the hygiene hypothesis was proposed. And we all now know that hygiene hypothesis definitely makes sense, but there is so much more complexity in the rise of allergy and the diet's role in the rise of allergy. And again, I would like to point you out to this beautiful paper in the Annals of Allergy, Asthma Immunology by a group led by Dr. James Walter, and on the origins of allergy from a systems approach, where they have so beautifully told us about how it is a complex interaction of all of this: inflammation, infection, the allergens in the diet, the food that has now changed, our changed dietary pattern, of course, our genetic predisposition, and the epigenetic changes that can follow. Altered microbiome, which to a large extent also is dictated by our diet, and a lot more, which we will see during the course of this session. And then, of course, the environment. Our environment has changed drastically to how our ancestors used to live. And I don't have to tell you about the harmful effects of pollution, etc., which are driving forces for the allergy epidemic. And also they have delineated very nicely the important drivers of asthma, atopic dermatitis, and food allergy. So definitely worth a read. Okay. So in summary, it's a microbial epithelial immune interaction and resulting in damage to the epithelial surfaces, which lies at the origin of the various manifestations of allergic diseases. And diet is something which is directly impacting on our gut epithelial surface and skin to a large extent too. So the start of the food allergy epidemic is a significant concern in medical literature starting from 1980s. And there was a BMJ publication in 1990 where they reported 4 deaths due to peanut allergy. This was a new thing in 1990. And then it was then declared that peanut is the most dangerous of allergenic foods. And in August 2020, the American Academy of Pediatrics on Nutrition established infant feeding guidelines. And although there was no conclusive studies to base these definitive recommendations, it was based on the remarkable rise that was being seen, and people were grappling to understand why this was happening. Okay, so what did the guidelines say? It said that the solid foods should not be introduced into the diet of high-risk infants till 6 months of age. Okay, and also it said that dairy products need to be delayed until year 1. Egg delayed until year 2. Peanuts, tree nuts, and fish delayed until 3 years of age. And this advice became widely followed. I'm sorry, there's a typo. It should read AAP 2000, not 2020. Apologies for that. But essentially, this advice became widely followed. And some even follow it up to date because that's what it was so prominent at the time. And then what they realized is despite this guidance of delayed introduction, the prevalence of food allergy went on rising. So clearly something was not right here. Okay. And then in 2008, the AAP clinical report came out that there is no support for restricting the diet of infants beyond 4 to 6 months of age as a way to protect them against development of allergic diseases. So what next? So now you have Professor Gideon Lack, who we all very well know, and along with Dr. George Dutoit, they published this article on the early consumption of peanuts in infancy being associated with low prevalence of peanut allergy. Now, this is well before the LEAP trial. So this was their hypothesis that despite guidelines recommending avoidance of peanuts during infancy in UK, Australia, and US, etc., peanut allergy still continued to increase. Okay, and there were countries where, like Israel, for example, where the incidence for peanut allergy was very low despite early introduction. So what was it that was resulting in this? So that's what they wanted to study. And then the LEAP trial was designed. So learning early about peanut trial, which we all very well are aware of now. And this was a randomized controlled trial of peanut consumption in infants at the risk for peanut allergy, at high risk for peanut allergy. And mainly they were in infants with severe eczema or who already had evidence of egg allergy. This was the cohort that they used. And what they found is that early introduction of peanuts significantly decreased the frequency of the development of peanut allergy among children at high risk for this allergy. And this modulated the immune response to peanuts. Now, this was a landmark study which told us that early introduction was actually protective. Okay, and then this was followed by the EAT study, which is inquiring about tolerance, where they studied the feasibility of early allergenic introduction. So they actually introduced early multiple allergenic foods to exclusively breastfed infants from 3 months of age, which is quite early, and studied various parameters. And then what they found is that food allergy prevalence was lower in the early introduction group, especially for peanut and egg allergy. And they didn't see a significant difference for milk, sesame, or the other allergens, but peanut and egg was quite obvious. Now, you also need to be aware of the health nut studies, which is an Australian cohort, where again beautiful study and prevalence of food allergy and other allergenic diseases in early childhood in a population-based study is being followed. And so this publication is from July 2017. And this is a summary of the study. Basically, what they found is that 10% of 1-year-old infants had food challenge proven food allergy to at least one of the common foods. Now, this is a staggering percentage, 10% of 1-year-old. And they're talking food challenge proven food allergy. So this is very worrying. And infants with vitamin D insufficiency were more likely to have multiple food allergies rather than just a single food allergy. And peanut allergy was 3 times more common in infants with parents born in East Asia. Okay, whereas rates of allergic diseases were pretty much lower among the Asian parents. So their offspring were more likely to have peanut allergy. And infants with eczema were 6 times more likely to have egg allergy and 11 times more likely to have peanut allergy. So that's the importance of controlling the eczema well. And there's a lot of study ongoing about that too. So you have the Pebbles cohort, Pebbles study, which is still happening, ongoing now. Again, that is definitely a study to watch. And then early exposure to cow's milk protein was associated with a reduced risk of developing CMPA. This data they brought out in 2018. And another interesting thing they brought out in 2020 was that no child who ate cashew by 12 months developed cashew allergy. So this suggests that we need to introduce all foods early in their complementary feeding. Okay. And then they brought out this is published in 2024. And here they're looking at prevalence of IgE-mediated food allergy and other allergies in the first 10 years. So this is also an extension of the Health Nuts study using the Health Nuts cohort. And again, quite alarming results that has been found. Now, this is obviously Australian data, but if you can look here, the results, you have 36% of 6-year-olds had at least one current allergic disease at 6 years of age, 36%, a very high number. And you had 38% of 10-year-olds having at least one current allergic disease. Very, very high percentage. And then food allergy occurred in about 6.4% of 6-year-olds and 6.3% of 10-year-olds. So 6% of the 10-year-old population of that country has a food allergy. And the other worrying thing is that allergic diseases affect 40% of primary school-age children, and 1/3 have multiple allergic diagnoses. And challenge-confirmed food allergy prevalence remains very high. 45% of the infants with food allergy have persistent disease to age 10. So we always have thought that, food allergy, a lot of children tend to outgrow, particularly milk and egg allergy. But here what they're finding is 45% of these infants who are diagnosed with food allergy persist to have their diagnosis at 10 years of age. Now that is extremely worrying. So what is the situation in Asia? So this is from a 2019 publication by the Asia Pacific Allergy Association. So basically, prevalence of food allergy in preschoolers is 1% in Thailand, 5% in Korea, and 7% in Chinese 2 years old. And cow's milk and egg allergy are most prevalent in under 2. And that is the pattern we see here too in India. And in Southeast Asia, shellfish allergy is the most common in older children, reflecting their dietary pattern too. And wheat is the main cause of food anaphylaxis in Japan and Korea. So you see how there's a variation in different Asian countries based on their dietary patterns, etc. What about situation in India? Actually, I'm not going to dwell much about this because Professor P.A. Mahesh is going to talk in detail about this. So I will skip this part. But I would like to point out the IACI guideline about preventing the development of food allergy in infants and young children. Now, this is the 2020 update. And what is the synopsis of this guideline is that regarding preventing the development of food allergy in infants is that you need to avoid use of regular cow's milk formula as supplementary feed for breastfed infants in the first week of life. Okay. Now, we all know that it's very common practice, particularly in urban areas, where in the first few days, infants may be given cow's milk-based formula until breastfeeding is established. But we need to try and avoid this as much as possible, given the safety scenario for the infant. Introduce well-cooked egg in the infant diet as part of complementary feeding. In populations with high prevalence of peanut allergy, introduce it in age-appropriate form as a part of their complementary feeding. So IACI guidelines say 4 to 6 months, but we all know that in the Indian context, we suggest exclusive breastfeeding till 6 months of age. But certainly beyond 6 months, we introduce complementary feeding. A variety of foods are introduced. and nuts must be a part of that variety too. Okay. And there is no recommendation by this IACI guideline for or against prebiotics, probiotics, vitamin supplements, duration of exclusive breastfeeding, and so on and so forth. Okay. Now, this again, this is a very important article on the maternal diet index in pregnancy associated with offspring allergic diseases. The Healthy Start study. Again, we as allergy practitioners need to be aware of the Healthy Start study. Again, Professor Mahesh is going to cover this later on in the panel discussion. So I'm going to skip it from that point of view. Okay, but again, very interesting findings, which essentially promote usage of more fiber in the diet, vegetables, fermented foods like yogurt, etc. But Prof. Mahesh, I'm sure, will cover this better than me. Again, dietary factors during pregnancy and atopic outcomes in childhood. Now, this is a systematic review from the European Academy of Allergy and Clinical Immunology, published in 2020. And what does this say about diet in pregnancy? So they have looked extensively at various studies, and what they found is that there's a lot of variation in design and dietary intake patterns, and often they found some contradictory findings. But they did find that vitamin D supplementation is associated with a reduced risk of asthma. A positive trend for omega-3 fatty acids was observed for asthma and allergic rhinitis. It did not reach statistical significance, but they did find a positive trend. And they did not find consistent evidence regarding other dietary factors in this systematic review. Okay? But moving on, so this is much later. So this is May 2023. Prevention of food allergy in infancy. Here, the role of maternal interventions and exposure during pregnancy and lactation. So pregnancy and lactation both are covered here. What is the summary of this important review regarding prevention of food allergy in infancy? So here, what they found is that there is no role for maternal dietary modifications during pregnancy or lactation, such as allergen avoidance, as a means of infant allergy prevention. So it's important that the mother eats a variety of foods, which is a part of her usual diet, preferably locally available. Although exclusive breastfeeding is a recommended infant nutrition source globally, the effect of breastfeeding in infant allergy prevention remains unclear to make a definite recommendation. But we would definitely endorse breastfeeding for all the other great benefits that we all are aware of. There is emerging evidence that irregular cow's milk exposure, so a little bit exposure here and there, that is infrequent formula supplementation, may actually increase the risk of cow's milk allergy. Now, although further studies are required, there is emerging evidence that maternal peanut ingestion during breastfeeding, along with early peanut introduction in infancy, might have a preventive role. Now, the other effects like dietary supplementation with vitamin D, omega-3, prebiotics, probiotics are as yet unclear. Okay. Now, again, I just wanted to highlight to you the effects of food processing on allergenicity. Now, we've all seen how our dietary pattern is changing quite dramatically, particularly in urban India, and rural India is soon following in that trend. We have seen, if you go to a village, you'll see a lot of children eating packaged foods. Ready noodles, processed chips, biscuits, etc., is becoming a very prominent part of their diet. So it's important we understand this and see how we can prevent this. So I just want to highlight regarding the processing, role of processing in allergenicity, that roasting increases allergenicity quite significantly. So in the context of peanut particularly, as a part of why peanut allergy became so prominent and such a major problem, is that a lot of the Western population will consume peanuts in the roasted form, as against what we would consume as the boiled form, etc., or we even eat it raw. So roasting increases the allergenicity of certain foods. Certainly for peanut, that is true. And there are a lot of other alterations that happen in food products. In the interest of time, I won't be covering this, but this is available for reading. You can go through this article, very recent article, January 2025, in Springer Nature. Yeah. Now, this is something I wanted to highlight, the role of ultra-processed foods, which have become so commonplace these days, even in India. So ultra-processed foods, allergy outcomes and underlying mechanisms in children. This is again IACI Task Force report from 2024, September 24. And what is the findings of this systematic review? So commercial baby food intake was associated with childhood food allergy. Now, a lot of our babies are now fed on commercial baby food rather than homemade food. This is a very worrying trend, certainly increasing again in urban India, not far in rural India, but we do need to do something to change this trend. Childhood intake of fructose, sugars, fruit juices, sugar sweetened beverages, which are so prevalent now, high carbohydrate, ultra processed foods, which are very commonplace, monosodium glutamate, MSG, ultra processed foods, and advanced glycated end products, which are very much seen in fried foods, for instance, was associated with the occurrence of allergic diseases. So, all these things, which are so commonly consumed as processed foods, packaged foods, are definitely associated with the occurrence of allergic diseases. Exposure to ultra-processed foods and common ingredients seen in them, like emulsifiers, etc., seem to be associated with increased occurrence of all allergic diseases, asthma, wheezing, food allergies, atopic dermatitis, rhinitis in many but not all studies. And what they have concluded is more preclinical and clinical studies are definitely required. So, caution, we in India are seeing a definite rise in food allergy, and there are so many contributing factors that we have just gone through. There is an urgent need for interventions to prevent this explosive food allergy epidemic, maybe even a tsunami. So I would also like to highlight the IAP action plan, guidelines for complementary feeding, which is so simple and so beautiful regarding the feeding of an infant beyond 6 months of age. And the Indian Academy of Pediatrics definitely recommends exclusive breastfeeding till 6 months of age. And this is the guidelines about what should be used as complementary feeding. And if you look at the appropriate food, you will find they're all homemade food, which are part of our daily Indian diet. How to supplement them with adequate protein and nutrition is nicely covered here too. And if you can see on the right, the avoidable complementary foods, they're all the processed foods, which we need to avoid. So just following this simple recommendation may do a huge favor for our children in the future too. And this is the evidence summary, the diet for allergy prevention. And as yet, there is no evidence to suggest that exclusive breastfeeding for 6 months or more is superior to exclusive breastfeeding for 4 to 6 months in terms of developing food allergy. Now, this is mainly from Western evidence, but we will stick to our recommendation of exclusive breastfeeding for 6 months for all the other benefits provided by breastfeeding. Okay, and the other important thing I want to highlight is no evidence to support delaying the introduction of solid foods beyond 4 to 6 months of age. So early introduction is something that we definitely need to highlight. Introduce low-risk complementary foods one at a time in the beginning, and then soon after, introduce potentially highly allergenic foods. More important for the high-risk infants with a family history of allergy or with patients with eczema or any other food allergy, for instance. Also, currently, there is no evidence to suggest use of pre or probiotics in allergy prevention, but probiotics certainly may reduce the incidence and severity of eczema. There is some emerging evidence in this, certainly a space to watch. As we all know, there is extensive studies being done in pre and probiotics. Early introduction of peanut significantly decreases the frequency of development of peanut allergy among children at high risk for this allergy. And early peanut introduction lowers the risk of development of peanut allergy by 80% compared with peanut introduction after the age of 5 years. Again, very relevant for the Western population, but the way we are going, it is also relevant that we emphasize to our parents that please introduce allergenic foods, including nuts, early, after 6 months, after exclusive breastfeeding, during the phase of complement feeding introduction. Now, I want to end with the fact that that men don't learn very much from the lessons of history, And that is the most important of all lessons that history has to teach us. So I think we should not make this mistake. We should learn from the mistakes that have already happened, and to prevent the allergy epidemic that definitely is anticipated to follow in our country. And it's all of our responsibility to do so. Thank you very much for your kind attention. I'll stop screen sharing. Has my screen sharing stopped?
Not yet, not yet, no.
Not yet? Okay, all right. Not sure why I'm not able to unshare. Any suggestions? So if I, you can see my screen now. All it shows here is share. Normally it says about stop screen share, isn't it?
Stop sharing.
Yeah, I'm not able to find that. I'm not sure why. What I'll probably do is just quickly leave the meeting and come back. Maybe then it will stop sharing, because I'm not finding that section. Hope that's okay.
All right, yeah, sure.
I don't know what else to do. All right, yeah.
Yes, I think now. All right, can you see the slide?
Yes, sir, it is visible.
Okay, yeah, thank you for that. Yeah, thank you, Nandana, for a very nice introduction. And I think you have very succinctly summarized, all the important, Western data. So let us now quickly look at what we have done from the data that is looking at the Indian population. So this is, I think, the only population-based study that has looked at not only the questionnaire, but also the skin prick test and the serum-specific IgE in the general population. This was done almost more than a decade ago. And again, one more general population study, but a questionnaire study was done by Neeraj. So let us see what we learned from that study. So probable prevalence of food allergy is around 1 to 2% in most countries, but you see that in Australia and New Zealand and some of the Western countries, it is very high. So Europrevall, before that, whatever data was available was from the clinics and hospitals, and there was no population-based study. Now, this still remains the largest study on food allergy. We screened about 32,000 subjects in India, and we did it in Mysore and Bangalore. We had 65 wards in Mysore, and we were given 30 randomly selected wards from the UK. Bangalore had about 100 wards at that time, and again we were given about 30 wards in that time. And even in each ward, it was a random selection of the households. We made a list of all the households, and it was a random selection of households that we included. So it was a truly randomized study based on the highest strict principles of the epidemiology. That was in phase 1. In phase 2, we had about 822 subjects, part of the case control study. We in India studied both adults and children. They included 3 countries in the so-called INCO group, or the International Cooperation Group. Almost all the European countries were involved. It was a 165 crore project, 65 centers across different countries in Europe. And 3 countries joined for tropical, that was India, and then subtropical, that was Hong Kong in China, and China also recruited, Gary Wang recruited centers in mainland China as well, and subarctic, that was Siberia. Different genetics, different cultures, different food habits, different environments, and they wanted to control this and compare this to the data from Europe. So that is why in the second phase, 3 countries were included in the study. And first, let us look at the data from adults, and we had exactly the same data in children when we compared this to other European countries. And what you can see here is that for almost all the foods, blue is the data of sensitization, serum specific IgE, that gives you the percentage in the Indian population. Brown, thick brown is the average for Europe, and then you have different European countries that participated in the adults. There were other centers that participated in the children study. So Zurich, Madrid, Utrecht, Lords, Sofia, and Reykjavik in Iceland. All of them participated in the adult study. Even if you look at foods, for example, kiwi is not very commonly consumed in Mysore, maybe a little bit more in Bangalore, but still very, very low. If you look at celery, we hardly consume that at all. So for most of the foods, even those that are not commonly consumed in the Indian population, the presence of specific IgE was much, much higher than the European population. So that was a very important or a key finding. If you look at the weighted prevalence, the specific IgE we told among the whole population is about 26.5. In India, because of the presence of Ayurveda that places a lot of emphasis on food and relation to all the diseases, a lot of people in India, almost 1 in 5, felt whatever symptoms they had, they were all related to food. So if you ask them their clinical symptoms, 1 in 5 will tell them that I have this food and this food is causing me this problem. When you look at the prevalence of the probable food allergy, that is, the patient should complain of symptoms related to a food and he should have specific IgE to that particular food, and the symptoms should occur within 2 hours after consumption. So this was the definition of the probable food allergy that we used, and in adults it was about 1.2% of the people we did. But that's in the second phase. If you take the overall 32,000, having just about 21 cases we had, including adults as well as children, that's a very, very low number. If you take the whole 32,000 people that we screened, it's a very, very small number. But what we found that Indians are very high IgE producers. If you look at the mean total IgE, because we had some people in the extreme 5,000, 10,000, and these people had absolutely no allergic disease at all. And mean was around 550. So we took the medium because it was not, the data was not normally distributed, and the median is around 237. So in the lab, for the doctors to look at total IgE, the lab says the top limit is 110. That is for the Western population. That is not for the Indian population. Indians are very high IgE producers. IgE is not only relevant for disease, it is absolutely critical for our health. It is not only for the helminthic infestation. We are bitten by a whole lot of insects. We have ants, we have mosquitoes. So who is going to detoxify that venom? IgE. We eat a lot of a different variety of foods. Again, all those irritants, who is going to detoxify that? Again, it is IgE. And if you see populations that have high total IgE, other parts of Asia, Africa, you will find that the prevalence of cancers are low. Death rates are high because we lack the best of the treatment. But if you look at absolute prevalence, we have like 5 or 10 times lower cancer prevalence as compared to several of the Western countries. So IgE has a lot of beneficial effects. There's a beautiful paper in Nature that actually discusses an entire review that discusses the benefits of IgE. So we learn IgE for disease. It's absolutely critical for our health as well. So we found that if we were to divide them as the population with IgE less than median and more than median, you will find that most of the kind of positivity that we got were related to people with total IgE. So people with total IgE, which is higher, will have a higher prevalence of a positive serum specific IgE. Remember that this is the general population. This is not the disease population. They don't have any allergies. But Indians are very high IgE producers. So if you want to interpret IgEs, including serum specific IgE in the Indian population, you should be very careful, especially if their total IgE is more than 237. If their IgE is low, we found that this is also the prevalence of serum specific IgE that is positive more than 0.35 is also low. Same thing we found with the aeroallergens. We found 1/3 of the population sensitive. Again, this is general population. They don't have any disease, including asthma, rhinitis. 6 of the allergens were tested. This is the positivity rate. Any allergen is about 1/3 among the 6 that were tested. Again, it was very closely related to the total IgE. If the total IgE is more than 237, you have more than half the population who will show a positive test, even though they don't have any clinical overt disease. Whereas if the IgE is low, this also reduces. It's very important to look at skin prick test, that is the gold standard, and compare it with serum specific IgE. Now, if you look at countries such as, for example, Norway or the Netherlands, the skin prick test IgE or the serum specific IgE are equally good. They are quite good. This is in general population. If you look at India, for example, very high positivity to the blood test. But if you do a skin prick test in a normal person, about 5 to 5.5% of them are positive. This is the, again, healthy population, not a diseased population. But about 40% will show a positive test. And if you compare the same thing, it's very, very low when you do a skin prick test, because skin prick test measures IgE fixed to the mast cell and basophils, whereas serum specific IgE measures the free IgE in the blood that may not be clinically relevant. If you go to some countries like Indonesia, and you can serum specific IgE is to the roof, 80% of them show a positive, whereas very low percentage of people actually show a skin prick test positive. So if you want to do an allergy test in India, where the population total, the total IgE is very high, it's better you do a skin prick test. That's going to be more clinically relevant than a blood test. That's the most important message when you compare all these different countries. We looked at infections and food sensitizations. If you look at Mysore and Bangalore, we had a lot of anti-HPA antibodies. Again, these were all healthy people. They did not have any major disease, but they had antibodies. They had some mild infection. And almost more than 90% and nearly 90% in Mysore and Bangalore. The only country that had high anti-HPA antibodies was Greece. And guess which country had the least food allergy prevalence in Europe? That was Greece again. So possibly these infections, parasitic infections that actually are not severe enough to cause disease, have some effect in modulating the immune system so that our prevalence of allergies are possibly lower. Now, this is in children, and these are the two centers from the mainland China that joined later. And Hong Kong was the initial center, and then Gary Wang got the mainland China also involved. Siberia in Russia and India. If you see, and this is children, totally about 35,000 children data is there from these 5 centers. And if you look at any food, it's very high in Hong Kong, Chaogan, and this is the rural China. India is also a very high IG producers. Russia was lower. And I won't go into the details of each of these foods, but this is the prevalence of the sensitization to specific IG. You can start looking at India for different foods. Shrimp was very high, and possibly that was due to cross-reactivity to the house dust mite. The most common sensitization of air allergen in India is due to house dust mite, which cross-reacts with the shrimp. This is the Indian kind of positivity. Is even if you look at foods like celery that we don't consume or peach that we don't consume, we have a lot of high IG. If you look at rural China, it's in comparison, it's very, very low. Again, these are kiwis, very rarely consumed, but you do find that there's a very high rates of specific IgE. This is for the beet, banana, tomato, carrot. This is for lentils, sunflower, melon, poppy. Very high IG. Compare this to rural China, you hardly get anything there. Compare this to Hong Kong, this is children, we are very high. Now coming to probable food allergy, just like in adults, probable food allergy means there is symptoms within 2 hours after eating that food that is related to an IgE mediated disease, and there is specific IgE to the same food. Now, if you start looking at that, now you start seeing the exact reversal. Hong Kong starts becoming more and more. India is very less. If you look at peanut, it's like 0.02. That's, that's very, very low. Look at most of the foods, we are in zero. Even other countries also, even Russia and mainland China and Hong Kong also had much lower prevalence of probable food allergy compared to the Western world. If you see almost all of these, you are seeing it's all zero. Very low, we had 2 India-specific foods, brinjal and as well as chickpea. We had 1 case and we had 2 cases after screening such a large number of the population. So the key lesson is that we need to be very careful when we are interpreting serum-specific IgE in the Indian population. More than 26% of the normal population are sensitive. More than 32% are sensitive to one of the common air allergens without any clinical disease. So we really need to study what are the protecting factors. So one of the things that we looked at the non-vegetarians and vegetarians. Again, compared to the Western world, the non-vegetarians in India don't consume it 3 times a day, unlike in the Western world, maybe a couple of times a week. But if you look at the sensitization we had for any of the sensitization for inhaled as well as for foods, you will find that if it is a non-vegetarian, about 21.22% of the people, whereas it's only about 6.33, 18 versus 3.8, 15 versus 2.3. So possibly the first time I looked at the data, I was really, wondering how diet seems to have an impact. And we actually rechecked the data a couple of times and found that it is true. And then I was really wondering what could be the reason. And again, there was a nice paper in Nature in 2009 that actually looked at how dietary intake of the fiber could have a bearing. We don't have any enzymes to digest the fiber, but we have more number of microbes in our body than the human cells. And the microbes in our gut do have the enzymes to digest the fiber. And when they digest the fiber, what you're going to have? You're going to have these important molecules, short-chain fatty acids, polysaccharide A, and peptidoglycans. Out of these, the short-chain fatty acids is probably the best studied now, but all 3 are quite relevant. And why is this important? If you look at the short-chain fatty acids and look at every one of our immune cells, they have a receptor called as GPR43. And the only thing that binds to the GPR43 is a short chain fatty acid. And it is present on, every single immune cell that we have. So consuming greater amount of fiber leading to the presence of the short chain fatty acids binding to the GPR43 leads to immune homeostasis. And that's why, it is the old adage that says we are what we eat. And our diet, I strongly believe, which we can easily modify, has a big bearing on how our immune system develops either tolerance or disease. So this study shows only association. This is not causation. You need birth cohort studies. I do believe diet has a potential to modulate the immune system, but we need randomized controlled studies. And there are few countries in the world that can actually do these kind of studies, because, of course, now the kind of vegetarianism is increasing in the West, but a pure vegetarianism that you would get in India, you will not get it in any other kind of country. So our pediatricians should lead these birth cohort studies. Thank you very much.
Thank you so much, Professor Mahesh, for that really insightful talk. The data was presented so clearly, and the lessons learned are absolutely important. And I really admire the way you presented it so clearly, and take on board that we definitely need more studies locally in our country. I can't stress how important that is going to be in the way things are coming in terms of the allergy epidemic. Sorry about the technical glitch earlier. I missed introducing you. But I think Professor Mahesh needs no introduction. And without much ado, we will move on to the panel discussion. Thank you so much. So Dr. Balchandra is going to moderate this panel discussion. Dr. Balchandra is a good friend and colleague. He is a very accomplished senior pediatrician and allergy specialist based in Bangalore. And he is a consultant clinician, pediatrician, allergist at Manipal Hospital and Chirayu Multispecialty Clinic. He's the course director of various allergy courses now, and is also the director of MedTrain, director of Allergy Central, which is a center of excellence in allergy, and director of Adya Health Sciences Private Limited. Dr. Balchandra is also an excellent teacher, and I look forward to this panel discussion. Over to you, please.
Yeah, thank you, Dr. Nandana. I would like to thank IAP Allergy Chapter, Dr. Neeraj Gupta and Dr. Nandana for asking me to do this most important panel discussion. So I will be sharing my screen. Let me know if my screen is visible. Is it visible?
Yes, it's visible. Yes.
Just a second. Okay. Okay. So I believe that this is one of the important panel discussion which I'm going to do. The reasons are because, as Dr. Mahesh sir told, that we are what we eat, and there is a lot of confusion or dilemma exists in this own topic of what to eat, what not to eat, and not just in the medical community, among the public or among the patients also. So to discuss this important topic, I have a great team with from diverse background. So to start with Dr. Mahesh PA, who is a consultant pulmonologist and was trained in UK and USA, and is a professor in pulmonary medicine in JSS Medical College, and is also a chairman in Indian Chest Society Karnataka chapter. So there are a lot of details which I have to speak about Dr. Mahesh sir, but I'll make it very short and crisp. So he's got about 452 publications and 419 international and 32 national and 4 books. He's written 16 chapters, and It is indexed in Google 213 times, and then total citation of 1,57,885 and an impact factor of 36.7. Is listed as top 2% of all the researchers in the world consecutively from 2020 to 2024 by Stanford University. And it's also the field of medical and health sciences based on citations in the last 5 years, ranked as first in the world in 2023. So we have Dr. Priyanka Hudawat, who is our pediatric gastroenterologist, hepatologist, and she's done her diploma in International Board of Lifestyle Medicine and an advanced course on diagnosis of allergy and immunotherapy. She's a consultant pediatric gastroenterologist and preventive healthcare and wellness allergy sciences. And she is in the current position of Institute of Gastrosciences in Sir H.N. Reliance Foundation Hospital, Mumbai. And we also have Dr. Lavanya R. Padmanabhan. She's a pediatric gastroenterologist and hepatologist from Rainbow Children's Hospital, Bangalore. She's trained in pediatric gastroenterology and hepatology from King's College Hospital, UK, and she's worked as a pediatric consultant in pediatric gastroenterology, the Royal London Hospital, UK. And we have Dr. Malati Vora. She's a PhD in nutrition and she's a keto dietitian. She's a consultant and HOD in nutrition and dietetics, Rainbow Children's Hospital, and visiting consultant at Synapse Neuro Health Center. So as I told, we have a researcher, we have a pulmonologist, we have a pediatric gastroenterologist, and we have a specialist in the functional medicine, and we have a dietitian. So we have the excellent team to discuss on this. A lot of data has been presented by Dr. Nandana and Dr. Mahesh sir. Now what I will be dealing on is mostly into the clinical context. As a clinician, as a pediatrician, what are all the kind of a different situations I come across, the different questions I do face from my patients. And with this data and with an available data, how do I handle this circumstances is what I'm going to focus on. Now, my first question to is Dr. Mahesh sir. Now, part of it has already been answered. There is a prediction that after a respiratory allergy attains a plateau, it is expected that the food allergy will be the next epidemic. And as pediatricians who are the listeners for this CME, what is your important comments on that? Dr. Mahesh sir, it's up to you.
Yeah, thank you, Bala. I think it is a very, very important question. And in most countries in the world that have seen an explosion of respiratory allergies, after 2 decades, they have started seeing an increase in food allergy. Now, compared to, say, 2 decades ago, when I talked to my colleagues, fortunately for me in Mysore, the food allergies I see are those patients who come from Bangalore, and especially those who come from abroad and the child was born abroad. It is still rare for me to see a child born in the Mysore area to come with a clear case of food allergy, fortunately. So, but when I talk to a lot of my colleagues who are in the metros, they are now seeing a lot of food allergies in children born in the metro. And not only those children who come from abroad, because if the child is born abroad, it's a John Warner study that looked at children who are born from the South Asia, either India, Pakistan, Bangladesh, Sri Lanka. If the child is born in India, migrates to UK after 5 years, it retains the same risk as an Indian child who stays in India. If a child, second child for them, the same parents is born in UK, the risk is equal or even greater than a UK Caucasian child. And if the child migrates before 5 years, then the risk is intermediate. So this is very important study in UK, and that looked at what happens when people migrate, because it's the same genes, and clearly highlighted the impact of the environment and the diet and the food. So I think definitely there is going to be an increase in the metros initially in India. And I hope the tier 2 and tier 3 cities will retain their diet. And then we are not going to see the kind of explosion of food allergy we see in the West.
Thank you, sir. Now I would like to ask Dr. Lavanya, what is the pathophysiology behind food allergy and food intolerance? Because many a times there is a lot of confusion. Patients come with a food intolerance patient believes that they have a food allergy, and food allergy patient comes with food intolerance test. So it's quite confusing. So please give us some examples, and if possible, please classify different food allergic conditions also.
Thank you, sir. So food allergies and intolerance, they're both a hypersensitivity reaction by the host to a particular food. But as rightly sir already said, they're completely different conditions. Food allergies are always immune-mediated reactions, whereas food intolerances, the immune system is not involved. There are other factors that come into play. Now, in food allergies, most of the time, yes, predominantly gastrointestinal symptoms like diarrhea, vomiting, or blood in the stools, constipation can happen. But many children also present with other involvement of other systems like having skin rashes, urticarial rashes, hives, angioedema, or breathing difficulties, wheezing, respiratory distress. Severe cases, systemic symptoms, flushing, tachycardia, hypotension, and anaphylaxis. Even a small quantity of the offending agent, the allergen, can trigger a severe reaction in allergenic people. Whereas in the case of food intolerance, the symptoms may be predominantly gastrointestinal, very vague, like nausea, feeling uncomfortable, dyspepsia, bloating, flatulence, sometimes diarrhea. So occasionally they can also have urticarial rashes or headache because of the histamine release. And these symptoms are never life-threatening. That's a very important point. And many of these people with food intolerances will tolerate variable quantities of the same offending agent. They may be able to tolerate a small quantity of lactose, but not a bigger quantity. That is the main difference, which is not the case in allergies. The examples, food allergies and food-induced anaphylaxis, oral allergy syndrome or pollen food allergy syndrome, cow's milk protein allergy, which is very commonly we're seeing in the metros, food protein-induced enterocolitis syndrome, food protein-associated proctocolitis or food protein-induced enteropathies, and eosinophilic GI disorders. Food intolerances, common examples in the community, lactose intolerance, fructose malabsorption, or non-celiac gluten intolerance, reaction to the histamine that is present in the food, sometimes even psychological. And coming to the classification of food allergic disorders, it depends on the kind of immune response that is elicited in the host. IgE-mediated response, the classic examples are anaphylactic reactions, oral allergy syndrome, where you have a very localized severe reaction. And non-IgE-mediated response is the cow's milk protein allergy and FPICE and food protein-induced proctocolitis. Whereas in allergic or eosinophilic gastrointestinal disorders, including eosinophilic esophagitis, there's a combination of both IgE and cell-mediated response. Now, looking at why this happens, if we look at the figure, that's an intact epithelial lining, which is constantly being exposed to nutrients, bacteria, a lot of chemicals, drugs, and this separates the offending agents from the underlying immune system. So when this tolerance is lost, when there is an abnormal immune response elicited by a dietary antigen, that is called food allergy. It can be either Ig or non-Ig, as we already saw. It's due to a complex interplay of various factors, including genetic predisposition, as just now Dr. Mahesh also mentioned, impaired epithelial barrier function, dysregulated immunity, and various environmental factors. Now, some of the risk factors for these food allergies, whenever the mucosal lining is affected, it can be repeated gastrointestinal infections. It can be a change in the gut microbiome due to early use of antibiotics, repeated courses of antibiotics, early introduction of solid foods inappropriately, or when there is a defect in the immunity, a dysregulated immunity. Any of these or a combination of these leads to development of allergy. In the case of IgE, move on, sir, please. In the case of IgE-mediated reactions, as we can see in the second part of the diagram, food hypersensitivity. So the offending agent or the allergen is presented to the T cells by the antigen-presenting dendritic cells that stimulates the B cells to produce allergen-specific IgE antibodies. So these IgE antibodies are what we measure in the blood. These coat the mast cells and the basophils, and now they are sensitized. So when there is exposure again to the offending same allergen, there is a huge antigen antibody reaction happening and a degranulation of these cells, really leading to massive release of inflammatory mediators and histamine, which is what produces all these symptoms. Now, moving on to food intolerances, here the mechanism is not immune mediated. Various mechanisms have been postulated according to the condition. For example, in lactose intolerance, there's a partial or complete deficiency of lactase enzyme, which is the enzyme needed to digest the lactose, and fructose malabsorption, where there's just an issue with malabsorption. So the undigested or malabsorbed product is causing symptoms. Histamine intolerance, certain high histamine containing foods or liquids like alcohol, processed, highly processed meats and cheese can lead to histamine release response. Adverse reaction to various food additives in all these highly processed and packaged foods is common. And of course, not to forget psychological food intolerances.
Yeah, thank you, Dr. Lavanya, for helping us to understand the basic differences between the food allergy and food intolerance, and also giving few examples also. So moving on to the next question to Dr. Priyanka, how do you differentiate clinically between true food allergy and intolerance, and based on pure clinical basis, when a pediatrician is seeing this kind of a patient, and a brief overview on IgE, non-IgE mediated food allergy and food intolerance. Dr. Priyanka?
Yeah. So the basic difference, Dr. Lavanya has already told. So the basic difference here is when we are dealing with IG allergies, IG mediated or non-IG mediated, it is multi-system involvement. Where the food intolerance, it's the local GI involvement. So that is the main basic symptoms. But when it is IG mediated, symptoms will start immediately within few minutes to within 2 hours. And if there are delayed reactions, then it is non-IG mediated. So as I told, it is multi-system in IG mediated. So skin manifestations like rashes, urticarias, angioedema, then airway manifestations like wheezing, breathing difficulty, running nose also, and GI manifestations like nausea, vomiting, and just a food refusal, or very life-threatening like anaphylaxis. So those are more common in the IgE mediated. But when we talk about non-IG mediated, which is very difficult to diagnose. Why? Because there is no direct correlation with the food sometimes, because the reactions are happening late. So we have to have very close watch, and here growth will be affected. There may be chronic eczema along with all GI symptoms like vomiting, diarrhea, or just chronic pain. Abdomen also can be one of the cause, or because of chronic malabsorptions, sometimes the growth also can get affected in non-IG mediated, which is a more difficult part to diagnose directly. But in food intolerances, there will be definitely no, it will be dose dependent. If we have less, maybe you don't have the reaction, and if you have more, then there are sudden bloating or pain or cramps. Here the reproducibility, so whenever we have an exposure to the food, you have the allergic reaction, that is allergy mediated, which is IG mediated. But in food intolerances, sometimes reactions can be there, may not be there, they may wax and wane, depend on the quality and the quantity also, and they are not life threatening. Mostly they almost never life threatening food intolerances. But in IG mediated, we all know anaphylaxis can happen, and definitely we have to look at the enzyme deficiencies, which I think Dr. Lavanya has already told. So the next slide. So if we talk as an example, cow milk protein, which is very common in infants, versus lactose intolerance. A lot of parents comes and tells that our child is suffering from lactose intolerance, and that's a milk allergy actually. So as we said, all or none is milk allergy. Whether the lactose, mainly lactose intolerance we get, there will be acute gastroenteritis episode in infants or in young kids, and after that they say that we have problem with milk intake, which is secondary lactose intolerance because of deficiency of villus damage. Because of villus damage, there is transiently lactase enzyme is deficient, so that will recover in 2 to 4 weeks. But in milk allergy, cow milk protein allergy, multi-system involvement will be there: skin rashes, eczema, urticarias, even respiratory manifestations. And definitely mostly these food allergies grows by out of 4 to 5 year of age, but lactose intolerance within 4 to 6 weeks of time, or maybe within 1 to 2 months, you will recover once the villus epithelium is getting reset after the healing of the previous gastroenteritis episode, except in the primary lactose intolerance, which is very, very rare in India. As a pediatric gastroenterologist, I have never seen primary lactose intolerance, which is a genetic, where there is a permanent deficiency of lactase enzyme. So mostly we deal with secondary lactose intolerance, which is transient. So if we just say cow milk protein allergy, for IG mediated symptoms, they will come with immediate skin manifestations, respiratory or wheezing or cough. But in non-IG mediated, as a pediatric gastroenterologist, we see more like blood in stools. So if the proctocolitis is there, it is more fresh bleeding per rectum. If there is an enteropathy, see, if you have enteropathy, small intestines will be involved. So here malabsorption features will be there: watery diarrhea, failure to thrive, protein losing enteropathy. But if it is an enterocolitis, there will be profuse manifestations. There will be bloody diarrhea, anemia, more hypoproteinemia because enterocolitis. And if it is an upper GI involvement, then you'll have more vomiting, food refusal, or dysphagia like esophagitis. And gastritis can even present with some occult GI bleed or hematemesis also. And in non-IG mediated, skin conditions like atopic dermatitis and eczema and poor growth can be there. And definitely food protein induced enterocolitis syndromes, they have mixed variety, but they may present with severe manifestations, severe shock, acidosis, and dehydration, and severe vomitings. So these are the major chunks, but we have to be very, very careful with them.
Thank you, Dr. Priyanka, for making it so clear. Now, going back to Dr. Lavanya, I would like to ask, what is the relationship or overlap of food allergy with other GI disorders, other gastrointestinal conditions, and the food allergy? Is there an overlap, and how do you evaluate that? Dr. Lavanya?
Thank you, sir. Definitely, there is a overlap between food allergies and other gastrointestinal disorders, predominantly the functional gastrointestinal disorders like irritable bowel syndrome, or be it functional abdominal pain or dyspepsia or constipation. And that is predominantly because more than an actual association between food allergy and these conditions, the way they present, the symptoms and signs are many times common to both the conditions. And it's very difficult. There's no one sensitive or specific test to definitely differentiate between the two. Of course, apart from the IgE-mediated food allergies, the non-IgE-mediated food allergies and these functional conditions, the presentation would be more or less the same. And the symptoms may improve on exclusion diet, even in functional gastrointestinal disorders, where there is actually no allergic component, there is no immune reaction. That could be just a coincidental thing, or it could be due to various non-immune effects of the foods. For example, a person who has significant heartburn, dyspepsia symptoms, if they start avoiding milk products and they actually feel better, that may not be because of an allergic response that was avoided. It could be just because the gastroparesis improved, the number of reflux episodes improved, so they are feeling better. So this is why it is tricky. And moving on, there is a lot of data, literature, conflicting literature about why food allergy is implicated in almost all the gastrointestinal conditions. There are experimental studies to say they have found abnormal hypersensitive response in the intestinal mucosa of individuals who have functional gastrointestinal symptoms like IBS when they are exposed to the offending agent. But there is no documented immune response here. So I think the researchers are still working on this. And I would also like to mention the complex association between diet and inflammatory bowel disease, which is an autoimmune condition. It is not that if you have a food allergy, you have a higher risk of developing IBD. But definitely, both these conditions are immune mediated and they share a certain degree of common features in their pathogenesis, which is why we have established dietary therapies for Crohn's disease, well studied and well documented therapy. So I think this relationship is quite complex.
Thank you. So, yeah, as you told, there is a definitely, it is a tricky, and there is a overlap of significant amount of symptoms And definitely we need to have a broader suspicion and take the specialist opinion as and when required. Now moving on to Dr. Malti. There is a significant change in dietary patterns in India and mostly in the urban India. And there is a lot of effect on it on allergy. There is a rise of Western diet and usage of lot of packaged and processed food. So what do you think that effect of these food on the allergic diseases?
Yes, yes. Thank you, sir. As Dr. Nandana has already explained, definitely there will be an impact of this westernized diets on the immunity of the children. Changes in dietary patterns, especially the shift to a westernized diet with reduced dietary fiber and an abundance of processed foods, impact the gut and skin epithelial barrier and contribute to the development of chronic inflammatory diseases such as food allergy. Other factors are also there, like pollution, microplastics, use of medications like antibiotics. They also have a significant role in this food allergy development.
Okay, thank you, Dr. Malti. So that means that is more probably the reason why a Western population, or sorry, urban population have such kind of an allergic diseases, whereas probably 100, 150 kilometers away from that urban area, the number of allergic conditions are significantly lesser. So now coming back to Dr. Mahesh sir, now till now we discussed about the general questions and general differentiating factors. Now we would take a case scenario and then move on and evolve and see how an allergic, if there is an allergic patient or a family, how do we approach those patients and family? Now, given the scenario of a 32-year-old lady with a strong family history of allergy, and she's planning to get pregnant, and she's aware that allergy can come in their children because she's carrying that allergic probably genetics. Now, what advice would you give her in terms of minimizing the allergy risk in the baby? Dr. Mahesh sir, over to you.
Yeah, thank you, Bala. I think we don't have a very strong evidence to give a clear-cut answer, but there is some evidence which we can share with the mother to see whatever benefit she can accrue. So one is related to the maternal diet and then the infant diet. Second is related to the maternal environment. These are the two main things that can actually have a bearing. To put it very simply, I would suggest the pediatricians to tell all the mothers or even the gynecologists for that matter, if they follow the lifestyle of their grandmother, they will do very well. If they follow the diet of their grandmother, they will do very well. I think that's a blanket question. I think there's a lot of wisdom in India. I think that we are missing out now by following the Western people. But these have been developed, I think, over thousands of years. And I believe the Indian diet is like medicine. You follow how your grandmother processed the food, you do that. I think we'll remain protected. Now, this is a lot of this has come from the Western data. And one of the things that look at is the maternal diet. And they want to look at the balanced and the diverse diet that is rich in vegetable, fruits, yogurts, nuts, and whole grains. So there is a diet that has looked at the maternal allergy preventive diet index. So this is an index that has been studied in the Western world. I think Nandana also talked about this study. It's a Healthy Start study from the Colorado that looked at the mother and offspring diet. Diet is two of them. And they looked at the food questionnaires and then looked at the allergic disease in the offspring up to the age 4. And what they found is if the mother consumed less of the processed food and less of the non-vegetarian food, the mother did well. If you look at all the kind of diseases, including food allergy, and if the mother consumed greater fruits and vegetables and yogurt, the mother did well. Next slide. So this is the weighted coefficient that they gave, that the vegetables and yogurt were protective. This is increases the index, and as the index is increased, the mother is protected or the child is protected from developing allergies. So you find that the fried potatoes, even some of the what you get there, the grains may be highly processed, red meat, These again fruit juices that are available in the cans generally have a lot of sugar in them. And the breakfast, cereal breakfast that you get in the Western world, all of them actually contributed the risk. And if you look at not only the maternal diet index, they also looked at the infant diet diversity. And if you look at the infant diet diversity at 12 months, and if you look at the combination of the maternal diet as well as the infant diet diversity at 12 months, as this went on increasing, they followed the children up to almost 4 years. And as the infant diversity increased, as the maternal diet index was more positive, you will find that the food allergies are low. And as the infant diet diversity was low and the maternal diet index was more negative, then they had greater risk of these allergies. Next slide. So one of the key messages is avoid processed foods and even the canned with the high salt and high sugar and ultra processed foods. And how do they work? Maybe via the gut microbiome, disruption. No need for allergy avoidance. The mother can consume all the foods, that is better. Possibly supplement key nutrients such as vitamin D, omega-3 fatty acids, antioxidants which support the fetal immune development. Next slide. Coming to the environment, important, mother should not smoke. Nobody in the house should smoke. That is very strict, that has to be done. And for countries like India, Sandeep Salvi in Pune has done a lot of studies that shows each incense stick is equal to 5 to 15 cigarettes. One dope stick is equal to about 1,000 cigarettes. Mosquito coils is equal to about 150 and the liquidator 6 hours equal to about 100 cigarettes. So these are very critical in the indoor. These are so-called hidden things which people don't realize that are actually causing a lot of damage to everyone, and this goes from the womb to the tomb. There are studies that have looked at stress reduction and looks at anxiety, depression, and stress, and these are linked to childhood allergies. There is an 87% higher risk for wheeze and 140% higher risk for asthma when the mother has more depression and anxiety. And the effect was 3 times more on the female child as compared to the male child. Next. So take care to limit the environmental pollutants, including, for example, in a newly built house, you have a lot of this plywood, you have a lot of paint, and this brings in a lot of volatile organic compounds and lead. Promote the microbial diversity. Don't use too many antiseptics in the house. Because of those, we find that even fermented foods like the idli that you have, the quality that was there 30 years ago, you don't have now. Because 30 years ago, they just use soap to clean. Now they use an antiseptic to clean the kitchen. So bacterial flora is different. These natural bacterial flora actually ferment the food. And the quality of the idli today compared to 30 years ago is far lower. Next.
Yeah.
Thank you.
Thank you, sir. The key important takeaway point I understood is we should eat grandmother's diet and we should live our life also like a grandmother's lived.
Yeah.
And the way today urban lifestyle is definitely pro allergenic.
Absolutely.
Coming to the next question to Dr. Lavanya. 30-year-old, the same lady with allergic rhinitis, is breastfeeding her 1-month-old baby. Now our child has asthma and also had cow's milk allergy, our previous child. Now, what is the likelihood of this child developing allergy? And what would you advise in terms of diet to the mother during the breastfeeding?
Thank you, sir. So in this case, we have a breastfeeding mother who has atopy in the form of allergic rhinitis with her older child who also has atopy in the form of asthma and cow's milk protein allergy. So what's the risk for the current child? So from scientific evidence, what we know so far, risk of allergy or atopy is definitely higher in children who are born to parents who have allergies. And this is up to 60 to 80% if both the parents have allergies. And if one of the parents have any of the allergies, then the risk is said to be around 30 to 40%. And studies have also shown that if the mother has allergies and the father does not have, the child has a significantly higher risk compared to a child whose father has allergies and the mother is not. So if the mother has allergy, the child is more prone to become allergic. And siblings who have history of allergy, again, the risk for developing food allergies is doubled in the child. But the important point to remember in clinical practice is absence of a negative family history of allergy does not rule out allergies. So we should keep that also in mind. So this child is definitely predisposed to a higher risk of developing allergy compared to another child. So what's the primary prevention? We already heard from Dr. Mahesh and Dr. Nandana. Definitely, dietary exclusions are not advised during pregnancy or lactation for the as a primary preventive measure for so that the baby does not develop allergies in the future. Because dietary exclusions are dangerous during this very important period, both for the mother as well as for the infant. Now, dietary exclusions can be very carefully considered only if diagnosis of a cow's milk protein allergy or significant atopic dermatitis is made in the infant and the baby is being exclusively breastfed, then it can be carefully considered. But definitely not as a preventive measure before the baby is diagnosed to have any allergies. So no dietary exclusions at present.
So thank you, Dr. Lavanya. So that says that if there are symptoms, then go back, evaluate, and then try to avoid the diet or anything. But if there are no symptoms, then healthy diet is encouraged to the mother without any exclusions. Dr. Priyanka, this baby is now 5 months old, and mother is planning to start her on a complementary feeds. And this is a difficult situation. Now, this baby also has developed mild eczema from 2 months of age. Here, what do we advise, and should we have any avoidance for this baby? Dr.
So
Priyanka.
there should not be a blanket statement that avoid these foods, as it's a mild case, first of all, mild eczema. So we should start complementary feeds as we start for all. We can start with the low allergenic foods first, and as we do for other kids, we have to start at 6 months in pureed and mashed form. We can start with rice, pureed dals, mashed potatoes, pumpkins, papaya, so one fruit, one cereals and grains. Start with small amounts, 1 to 2 teaspoons a day, and then slowly, gradually increase as per guidelines. Continue breastfeeding. There is no need to even discontinue breastfeeding or exclude milk from mother's diet. That is also not advisable. And the only thing we should be thinking is, when we are introducing one food at a time, you start, don't start multiple foods. So if there is any correlation with the food and eczema, we will come to know. So we can start. And if we have to go for the allergenic food, next slide. So like wheat, eggs, peanuts, soy or fish, again, no routine avoidance is advisable. We can start after starting the low allergenic food, like between 6 to 9 months. Well cooked eggs and even peanuts, wheat and milk products also, and again introduced at home. So when you are introducing these allergenic food, we have to, the patient, baby has to be comfortable. In daytime we should do this, and there should not be any sickness, so that if any symptoms arises or if eczema increases, we know that this is the food which we may avoid for some time. So once food is tolerated, give it on regular exposure, like 2 to 3 times per week, to reduce future risk of allergies. And when there is mild eczema, good skin care, well hydration, daily emollients, these are very, very important steps, because if you have broken skin because of eczema, that may increase the food sensitization and risk of allergies. So there has to be good skin care, and because we all know that it may develop later on food allergies. So early introduction of these foods at home is advisable and generally safe. But when to seek help? if you start a food and there is an immediate reaction like hives or itching or vomiting or breathing difficulty, then we have to stop that food and advise them for urgent care by a pediatrician or allergy specialist. And there may be delayed reactions. That's why we said observe one food at a time for 2 to 3 days before we start introducing new foods, so that even delayed reactions can be picked up on time in the form of worsening eczema or diarrhea or blood in stools.
Thank you, Dr. Priyanka. You made it very clear that to introduce one food at a time, no blanket restrictions, expose all food starting from low allergenic to the expected allergenic food, but have a clear observation and do it in a particular way. So that's a clear answer. I think the audience would have got the answers. Moving on to the next question to Dr. Mahesh sir. A baby develops an extensive urticaria at 6 months of age following ingestion of a small amount of egg accidentally. Now, this is a child with atopic background and atopic family. What do we advise regarding egg? What do we advise regarding introduction of other common foods? And do we need an allergy test in this child who has already shown symptoms to the egg?
Correct. Yeah, thank you, Bala. I think we need to look at, for example, the pre-test probability and the post-test probability. So pre-test probability depends on your clinical history. Like, for example, the earlier the child reacts to less than 2 hours, higher is the chance that it's an IG-mediated allergy. If it comes after 6 hours, lower is the chance. If it is between that 2 to 6 hours, it is kind of intermediate. So you need to look at whether it happens repeatedly. Every time the child has consumed, it has a reaction. There can be a dose response. For a smaller dose, the reaction may not happen, but if the same dose is consumed, it must happen every time the child comes in contact with the food. So these are some of the simple clinical points in history that you can take. And if the child has, like in this child, that the example that we have just seen, there is a high clinical likelihood because the reaction has occurred within 2 hours. Then you go ahead and do a serum specific IG. If a child is 6 months old, I would prefer a serum specific IG. We can do a skin prick test as well because it's only urticaria and not anaphylaxis. I won't go to the details of the algorithm for the lack of time, but basically look at the clinical history at the top. Then you confirm there is a specific IG to that particular food, either by skin prick test or serum specific IG. And if there's a very clear history of reaction and a very clear specific IG is present, then you diagnose food allergy and you tend to avoid that food. If it is equivocal history, like I said, it's after 6 hours, or you do a skin prick test, it doesn't show that, a positive test for the egg. So these would need you to then go further down and maybe look at a component result diagnostics, for example, GALDI 1, GALDI 2, 3, 4, you may need to look at. Whereas then if you still have doubt, if there is access, you can do a basophil activation test, which is much stronger than a serum specific IG because it shows there is degranulation. And last and the gold standard to confirm the diagnosis is, of course, an oral food challenge test. And if it is positive, then you say there is actual food allergy and you try to avoid. But if all the things are negative, then it is due to something else and you can exclude an IG-mediated food allergy. Next. So if you do, for example, if you do a serum-specific IgE by immunocap, this is old data, but still holds good. For example, if you look at egg, this child age is less than 2 years, and the specific IgE for egg, for example, is 4. Then your chance of a positive, even on oral food challenge, is about 95%. So if there is a history within 2 hours and IgE more than 2 for egg in this child, you're almost 95% certain that the child will react to an oral food challenge test. And there is no need to do an oral food challenge test. So these numbers are quite useful for people to keep so that when you have a history within 2 hours and you have these values on serum specific IG, you don't need to even do the gold standard, the oral food challenge test. Next. So now to answer the three questions, what do we advise or tell the mother? We say we think your child likely had immediate allergic reaction to egg. Please stop giving egg and egg related foods for now. And then you can do a serial test to find out what happens to the specific IgE. If it keeps on coming down, about 50% of them can get out of the egg allergy over time. And you can kind of monitor the specific IgE to see whether it is reducing or increasing. If you have done a component result diagnostics, you find it child is allergic to GALD1, it is likely to persist. But GALD2 or 3 may come down with the time. Second question, what do we advise regarding introduction of other foods? You should continue introducing all the other foods, except for peanut, where studies have shown child with egg allergy have higher risk for peanut. And therefore, you may want to also test for peanut before you give peanut at home, or you can do a supervised introduction in the hospital, depending upon the IgE to the peanut. Next. All the other foods you can freely give. Do we need to do? Obviously, we need to do. You can follow the algorithm. And if once it is confirmed, it is best to avoid the food for now.
Thank you, sir. That's very clear. To Dr. Malti, this baby needs to exclude egg and wheat based on the history and the allergy test which has come out. Now, the baby is just 6 months and there's a long way to go. How do we ensure that the baby is getting required nutrition during the complementary feeding? And as a dietitian, what would be the role in managing this type of food allergy in your practice?
Yes, as Dr. Priyanka has said, like initially only single cereal to be tried, like rice porridge or soft rice and then ragi and all. Later on, cereal pulse combinations like health mix, cereal pulse mix, sattu porridge, ragi and millet, along with the dal Bengal gram, Hyderabad mix, Davangere mix. These things wherein cereal and pulse are also mixed. That can give good amount of protein and it can make up the thing like substitute for the exclusion diets with the egg and the child is going to be with the exclusion of egg and wheat diet, so definitely we need to add on certain foods like cereal pulse combinations, and then for the fiber spinach and amaranth puree, and also chickpea or cowpea paste can be used little later. So these are advised to provide adequate nutrition and to prevent nutrient deficiency and ensure growth and development. The child has to avoid egg proteins, including albumin, egg white, egg yolk, any form of egg dried powders and egg powders, and all wheat based products. And also look for ingredients like bran, bread, crumbs, rava, maida, biscuits, anything that is based with wheat. And label reading is very important. Carefully, they need to read, the family should read food labels to identify hidden sources of egg or wheat. Important steps are to eliminate, monitor, and reintroduce. So, elimination is the foods, as I quoted, all the egg and wheat products. Monitoring by parents or caregivers, keep a detailed diary of child's diet and any symptoms experienced. Reintroduction, as symptoms were suggested of IgE mediated allergy. Allergy test is performed after every 6 to 9 months. If the test is negative, then allergy specialist will conduct oral food challenge test in controlled hospital environment. If child is able to safely tolerate the food during test, then reintroduction is advised. So, coming to the role of dietitian in management of food allergies, diet planning and evaluation to be done carefully. Factors of allergies like ultra processed and processed foods and obesity to be emphasized, and educated to parents to prevent food allergies. Self diagnosis of food allergy and excluding various foods can lead to macro and micronutrient deficiencies. Accurate diagnosis and the correct treatment plan is very important. Coming to the role of dietitian again should be in terms of prevention, wherein we need to encourage the parents about more of immune supportive diet with 40% of animal based products and 60% of plant based foods, fermented foods, dietary fiber rich foods, flavonoids, unprocessed or minimally processed foods, locally available indigenous foods, moderate amount of omega-3 rich foods, variety of foods across and within all food groups that will give a balanced diet as well as a wholesome nutrition. And we need to promote increasing consumption of whole grains and fiber and cereal pulse combinations and fruits and vegetables, because that is lacking in many of the families. The children are not consuming more fruits and vegetables. Reduction in the consumption of refined grains and food emulsifiers, as well as artificial sweetness and packed and ultra processed foods, definitely has to be encouraged, to be reinforced by us. Thank you, sir.
Thank you. Thank you, Dr. Malti. So that's very important that as a role of dietitian, you need to make sure that the child's growth is optimal and the parents are well educated, not only directly, they may come across or indirectly, they may get consumed and then end up with a problem. So now we do have very short amount of time, so we'll go a little faster. So now to Dr. Lavanya, what is allergic proctocolitis and which foods cause them, and how do you manage this condition?
So allergic proctocolitis or eosinophilic proctocolitis. So this is a condition which usually presents in the first few weeks of life, and these infants are otherwise very healthy and well thriving. They present with episodes of fresh blood per rectum called hematochezia. Stools can be a little bit mucoid, and sometimes there is also increased frequency of stools. But the common scenario is there's blood streak, a speck of blood here and there. It may not be consistent in every stool. It may happen once in a week. It may happen few times a week. So this is a non-IgE mediated reaction. And the trigger factors could be any of the allergenic food. Commonest is cow's milk protein. Even cereals have been implicated in the Western world. Diagnosis, one is clinical. Sometimes the stool test, especially stool occult blood, helps. And it's confirmed by sigmoidoscopy with biopsies, where you can see some patchy erythema or erosions, and this bumpy nodular mucosa that we see is because of the prominent lymphonodular hyperplasia. The histology is non-specific, but it shows a lot of eosinophils. So the management, if it's very, very mild, it's a benign condition. So in very mild cases, exclusively breastfed and absolutely well children, occasionally it happening, you just observe, monitor them. It might improve on its own. Don't need to attempt dietary exclusions. But if it's a chronic process or severe hematochezia, then you could think about eliminating the offending allergens from the mother's diet. Again, one at a time. Commonly, it is milk protein allergy. And formula-fed infant, yes, do due consideration to change the formula to extensively hydrolyzed formula or amino acid formulas as required.
Thank you, Dr. Lavanya. What are eosinophilic esophagitis and eosinophilic gastroenteritis, and which foods cause them, and how do you manage this condition? To Dr. Priyanka.
So eosinophilic esophagitis is a chronic immune-mediated inflammation of esophagus, where eosinophilic gastroenteritis can be, it involves either stomach, small intestines, or colon. So in eosinophil, both are related to food antigens and atopy, and they may be chronic and relapsing conditions. So we should be very, very careful. So next slide. So here, mainly in eosinophilic esophagitis, patients will present with feeding difficulty, dysphagia, even with food impaction directly. In endoscopy, you can see here rings, furrows, and exudates. And in biopsy will be the confirmatory finding, where more than 15 eosinophils per high power field in esophagus, despite of adequate PPI therapy, and they may have associated eczema, asthma, allergic rhinitis. So be very careful if child is presenting with persistent vomitings and dysphagia, an atopic child. Please rule out EOE as a pediatric gastroenterologist. This child presented with food impaction at 7-year-old child, and we removed this bolus and we dilated. This is an EOE case at 7-year-old. Next slide. So here we've dilated the case, and in eosinophilic EGIDs, where there's gastrointestinal involvement apart from esophagus, it can present with mucosal disease like diarrhea, protein losing enteropathy. It can be a muscular disease where obstructions and strictures are presenting. It can be a serosal disease where ascites and eosinophilia. We commonly see the mucosal disease where there is a lot of hyper nodularity, atypical lymphoid hyperplasia in the terminal ileum. These patients are coming with recurrent pain abdomen. Sometimes we mislabel them as a functional abdominal pain also. Next slide. So you can see these are the real case scenarios where you can see duodenal nodularity, terminal ileal nodularity, and look at the numbers of eosinophil in histopathology, eosinophilic enteritis, 70 to 80 eosinophils in ileal biopsies. Next slide. So if you're suspecting eosinophilic gastrointestinal diseases, chronic recurrent symptoms, we have to evaluate them properly. If there's a history of atopic diseases in patient or in family, and if there is a peripheral blood eosinophilia, please post them for endoscopies and biopsies. The higher the number of eosinophils in ileum, if it is more than 50 and colon even 60, in duodenum somewhere around 30. So if more than that eosinophil numbers are present with nodularity, may not be frank ulcers, we have to label them. If there is a chronic recurrent symptoms, otherwise primary eosinophilia in intestines can be a normal finding also. So we have to correlate with the symptoms, and then tissue eosinophilia needs to be correlated here. Next slide. Common food triggers are cow milk and wheat, especially in eosinophilic esophagitis. The slide which I presented with food impaction was the milk allergic patient, and I diagnosed the skin prick test also. Milk was persistently positive. Rest all eggs, soy, wheat, peanuts, and fish, the all common food. Next one. So there are three types of dietary therapies. As an allergist, we always do skin prick test. Otherwise, as a pediatrician, six food elimination diet will also help a lot, like eliminating milk, wheat, egg, soy, nuts, and seafood. And sometimes if it's a severe case, we have to shift on the elemental or amino acid based formula also. All three have shown good improvement in cases of eosinophilic esophagitis. Next slide. So main therapy, definitely dietary elimination. Targeted elimination means SPT based dietary eliminations or empiric six food elimination. In eosinophilic esophagitis, PPIs, swallow topical steroids. Practically, we give budesonide respules mixed with honey and swallow it. If we don't have that meter dose inhaler, we can swallow that, and not to eat anything for 30 to 60 minutes. So the topical steroid therapy works in the esophagus when we are treating with EOE. But in eosinophilic gastroenteritis, there may be sometimes a role of systemic steroids, but even budesonide can help in the upper GI involvement. And if it's a lower GI, then you have to give, in severe cases, systemic steroids like prednisolone, and in mild cases, just a budesonide. Elimination diet, nutritional support, growth monitoring is very, very important. And in complicated cases, endoscopic therapies like dilatations are also required.
Yeah.
So role of...
Go ahead, Dr. Priyanka.
So role of gut microbiome, I think we have already discussed a lot about it, but few slides, because we all know the 70% of immune system happens in the gut, and dysbiosis will present with a lot of gut related disorders. Next slide. So mainly here we have to maintain the microbial diversity. We have to maintain the intact permeability. There should not be leaky gut, because the tolerance versus sensitization and inflammation happens in the gut. So loss of tolerance will happen when we have already discussed with ultra processed foods and red meat, and that's where the TH1, TH2 imbalance will happen. Next slide. So in gut microbiome, we all know immune tolerance happens because of the certain bacteria like lactobacillus, bifidobacterium. They actually work on T regulatory cells, where the anti-inflammatory cytokines will get released because of that. Short chain fatty acids are very important. Dr. Mahesh has already discussed about it. They will strengthen the intestinal barrier also, and they will modulate the dendritic cells and T regulatory cells. So that is the main pathogenesis of food allergy. And there are multiple evidence now coming up with the data that microbial diversity has to be maintained to reduce food allergies. Next slide. So here TH2 pro-allergic cytokines will be more if you have a lot of antibiotic use, cesarean sections, and lack of breastfeeding. So we will have less lactobacillus bifidobacterium, which is more positive bacteria for making this TH1, TH2 balance. So this is the pathophysiology we all know. Next slide. So basically, we have to maintain a healthy gut microbiome to prevent food allergies, as we discussed, starting with our genetics, our environment. Our rural environment was always good. Continued exclusive breastfeeding for 6 months. homemade high fiber meals. As a lifestyle medicine physician, we always say it's whole cereals, grains, fruits, vegetables, and seeds all together will give you a good gut microbiome and good bacterial diversity. Next slide. So these are the studies on gut microbiome and their effect on the food allergy incidences. And with lack of time, I will not go into the detail. Already research is there even in pediatric population also. So gut microbiome will give us the risk prediction that which child will develop the food allergy. And now we have stool gut microbiome analysis and metagenomics going on. And if there is a lot of role future, we have to do a lot of research on probiotics and prebiotics, that whether they will promote the tolerance, and emerging therapies on short chain fatty acid. And now we can focus on even personalized nutrition by tailoring the diet to according to gut microbiome composition of that particular individual to prevent allergic diseases.
Thank you, Dr. Priyanka, for giving it that insights on the gut microbiome, which is a lot spoken everywhere, but I'm sure that there's a lot more knowledge and data needs to spread across, and a lot more data needs to be built also. This is a last question to Dr. Mahesh. Indian population has high sensitization for food. That's already shown here. What lifestyle measures need to be followed to prevent progression to allergy? This sensitization may progress to an allergy. There are a few studies to say that people who are highly sensitized have a higher chances of becoming allergy. And what can be done to prevent this food allergy epidemic?
Yeah, Bala, I think that's a that's a very important question to ask. And one of the follow-up studies from the blood samples that we did with the Europrevall study showed that the sensitization is actually to the CCD, that's the complex carbohydrate determinants. And actually, sensitization to this particular part of the food actually doesn't lead to much clinical symptoms. That's also one of the reasons. But what we can do, if you can go to the next slide, we can quickly.
No.
Okay, don't have to say. Okay, just to summarize then, what can we do? Like I said, the very simple answer is to follow what our grandmother did. You look at the diet that we had, it's a whole food, it's a plant predominant diet. We talked of the impact of the vegetarian diet from the Europrevall study. Avoid all the excess sugar and processed foods and the artificial additives. That is important. Early introduction of the allergenic foods. This is more important for the Western world because the kind of food processing there is also different from how we process our foods. And once introduced, studies in the Western world have shown that regular ingestion actually helps. That is from the LEAP study, it has shown. Maintain diverse diet both in the mother as well as in the child during complementary feeding. Again, that is what studies have shown. Fermented foods in India, the idli, the dosa, the dokla, the yogurt, I think has a major bearing. The quality is not as good as it was earlier, as we discussed, because don't use too many antiseptics in the house. That's going to change the flora, microbial flora in the household, which will then translate to how these foods are fermented. And the oil bath, again, why, if you look at all the studies, we were part of the Global Asthma Network study, 100 country plus study, 9 centers in India, and almost all the centers in India had much, much lower atopic dermatitis or eczema compared to the Western world. I think the oil bath given to these children are absolutely critical, and this strengthens the skin, I believe, and which actually reduces the sensitization to foods through the skin. Whereas oral exposure leads to tolerance. They have done studies that shown that house dust mite has a lot of food allergens because the food is processed and that gets mixed in the house dust. And the child gets exposed to the skin, and this cutaneous exposure leads to very high risk of food allergy. So maintaining good skin is good. Then, of course, the physical activity, the stress, the sleep, all these becomes important. And basically, to put it in simple sentence, follow your grandmother's lifestyle, you will do well. Thank you.
Thank you, sir. I think we have had an excellent discussion, and I'm sure that many more questions will be there, but a good lot of questions and are solved in the listener's mind. So to conclude, I would like to thank all my panelists and Dr. Nandana and Dr. Neeraj for giving me this opportunity. Thank you, Dr. Mahesh, sir. Thank you, Dr. Priyanka. Thank you, Dr. Lavanya, and thank you, Dr. Malti. Just to conclude that, we are probably sitting on a next food allergy epidemic. Unless something drastically being done, we will be probably firefighting it in next few years down the line. And as sir told, grandmother's diet and grandmother's lifestyle is very, very important. And as pediatricians, pediatricians and probably gynecologists too, we are the first line who can probably make a difference. The physicians and other doctors do come later. We have the first role and responsibility, and if we fail in our responsibility, probably we will be facing this epidemic. And then a lot more data needs to be generated, Indian data, a lot more data needs to be generated in microbial, and also a good opportunity to conduct a lot of researches and publish Indian papers. So again, finally, thanking you for giving us this opportunity from my side and my whole team. Over to you, Dr. Nandana.
Thank you. Thank you so much, Dr. Balchandra, for that excellent panel discussion moderation. And I must congratulate all the panelists for providing your insights. It was really useful and very, very clear. And you so nicely discussed various aspects of the role of diet and allergy prevention, treatment, diagnosis of food allergy also was included partly, and that was addressed also. I think it was excellent and very clear. And I just want to point out that as Professor P.K. Vedantan sir has joined us. Sir, are you here? Sir, you're on mute.
I'm here. I'm having my breakfast.
Okay. Welcome, sir. Good morning to you.
I just have one or two comments. I'll be with you in few minutes. Okay. Thank you. Are you closing up?
Yes, sir. We are at the end of the session,
I
sir.
just have one question. One question. 1 second. I thank you for letting me in at the last moment. I listened to the lecture off and on because my morning schedule is sort of busy. I enjoyed whatever I heard. I enjoyed. Thank you very much. It's probably one of the most important topics being discussed today. The reason is, in my own experience, I find that we all do a fairly decent job in diagnosing food allergy. Okay? We know how to exactly do it. We have been taught well and we practice it. We finally come to say, you know, you are allergic to this particular food. So the next question, to me, is the most uncomfortable question. Parents say, so what do you want me to do? So you eliminate milk, you eliminate egg, you eliminate dal, so what am I supposed to do? Now the problem comes, I'm totally ignorant about nutrition. I'm totally ignorant about how to do recipes. So that is exactly what mother wants to know, is the recipe. And they want to know, how can my child have a nutritious food which is not allergic? I find many of us as allopathic physicians, we are very poorly trained in dietetics, okay, and nutrition. And that is, then we say, oh yeah, go and see a nutritionist, do a dietitian. You know, that is an easy escape. It is very difficult to do that because I myself find to find a good dietitian is very hard. So I want to know if there is a resource for Indian food, South Indian food, North Indian food, whatever. Is there a recipe book available which I can sort of suggest? Is there anything like an avenue for that when this question comes up? That is my question.
Yeah, that's a great question, sir. In fact, we have Dr. Malti with us, a very senior dietitian. She's a PhD in nutrition with a lot of experience. Dr. Malti, are you aware of any such Indian resource?
Yes, ma'am.
For-
There are some by ICMR, it is there, NIN, it is there, ma'am. But simple ones are there, wherein we need to again customize it as per the allergy specific scenario. And
I didn't get your answer. I could not follow. Sorry.
so there are certain recipes which is based with like common recipes which are nutritious, but again it has to be tailor made as per the food allergy, specific food allergies, which has to be done. Maybe it is a good insight for us to work on it and then something
Okay.
come up
So,
something in future. Yes.
so basically, what I'm getting from you is it's available, but it is limited.
Yes.
Okay. So that is the information I needed, because this is an area that needs to be explored. And this is what our patients, because I know here in the US, we have books on recipes. Actually, I used to work in an office, a very senior allergist office, which the practice that we took over later. There was one experienced nurse who had taken care of food allergic patients for about 20, 25 years every day. And she wrote a book on recipes, one of the most practical books for people, better than what is available in major bookshops. So such a practical book will help a lot of parents, So anyway, I appreciate your answer. And that is exactly what I wanted to get out from this talk, because most of the talk that was delivered today was excellent and was mostly towards diagnosis. Thank you very much. Again, thank you.
Thank you, sir.
Thank you. Thank you, Dr. Nandana.
Thank you, sir. Thank you so much for
Thank you.
joining us.
Yeah, no, I wish I joined more, for most of it, but it was whatever I heard was great. And I will
Thank you.
listen to the recorded session later. Thank you so much.
Thank you so much, sir. Thank you
Namaste.
for your
Bye-bye.
blessings. Yeah. Thank you.
Bye-bye.
Dr. Neeraj?
Dr.
So,
Nandana, can I take
at
up?
the outset, I would just like to, Dr. Bala, you want to say something?
Yeah, I'll just take up 10 seconds. No, I would like to thank Dr. Nandana for helping me in preparing the whole content and slides. She has put a lot of effort into that. Thank you, Dr. Nandana.
Oh, thank you, Bala. That's very kind of you. And I know that you have put in a lot of effort too. Thank you so much for that. Yeah.
So, from my side, I would just like to say thank you for such a brilliant session. And I think I would like to say very sincere thanks to Dr. Nandana, because this particular topic, which I usually felt that some diet is always something like the things are revolving around it. The diet is the culprit, diet is the answer. So diet is the thing which we never come to know that what to do, when to do, how to do. And that was the one thing which I wanted to really discuss and bring out. But Dr. Nandana has done a really beautiful job by, you can say, like bringing out so many things together, by bringing out so many experts from different arenas. The gastroenterologist being Dr. Mahesh by himself is an institution, Dr. Bala and Dr. Vedantan sir also. So I think it was like a fantastic episode, a fantastic webinar. Thank you everyone for this wonderful session. And I would like to say goodbye to everyone for now. And we will soon meet with another session. Thank you.
Thank you,
Thank
Dr.
you.
Nandana, for giving me this opportunity, ma'am.
Thank you, everybody. Thanks for
Thank you,
joining and
Dr.
agreeing
Nandana.
Thank you,
to
everyone.
Thank you, Dr.
attend today.
Bala. Thank you so much.
Thank you so much. Good
Yeah,
night.
Thank you. Thank you, everyone. Yeah, thank you, Neeraj, Nandana.